مساء الخير. Good evening. This is Sana Al-Sukhun, delighted to join you from Jordan. I'd like to thank Dr. Al-Ghazali and his great team for their effort organizing the meeting and inviting me, hopefully next year in the beautiful Cairo as usual. So I will be discussing why PARP inhibitors are a better option as compared to checkpoint inhibitors in the treatment of metastatic triple-negative breast cancer. And I will be starting by the optimal goal in the mind of each of us clinicians when treating patients with metastatic, particularly triple-negative breast cancer. We'd like to slow progression, induce response to alleviate symptoms, especially pain, and of course, improve survival, with the median of which we only have 12 to 18 months so far. Of course, while reducing adverse events, trying to preserve quality of life for our patients. And PARP inhibitors do provide that optimal goal, as I will share with you the rationale and the evidence soon. So what makes BRCA mutant triple-negative breast cancers unique as compared to other subsets of triple-negative breast cancer? They do have a mutant tumor suppressor gene, recognized in the early 90s, sequenced soon later to be described as a key protein in the DNA repair machinery for DNA double-strand breaks. Compare this to other triple-negative breast cancers, they do not have a target, particularly BRCA2, but that subset does have a target, which is the defective or mutated tumor suppressor gene BRCA1 or BRCA2. And why double-strand DNA breaks are important? Because they are the most cytotoxic to the cell. The cell is always exposed to insults and equipped with DNA repair machinery that is variable according to the insult. But when it comes to double-strand DNA breaks, the accurate homologous recombination repair is dependent on key proteins, among which are the BRCA1 and the BRCA2 tumor suppressor genes. So if it's defective, when the cell is exposed to insult, it calls upon helper machinery that is less accurate, the non-homologous enjoining repair and the PARP-mediated repair, resulting in chromosomal instability, accumulation of mutations, and the process of carcinogenesis and tumor formation. Makes sense to use PARP inhibitors to inhibit the alternative pathway so that once the cell is exposed to double-strand DNA breaks, hopefully that damage would be enough to cause cell death. So triple-negative breast cancers have a target and should be targeted with its targeted therapy. That concept has emerged from the early 60s, and it took 50 years to prove useful in the clinic. When the first Veliparib trial, proof of concept study, was published, Veliparib was used to treat a number of patients with BRCA-mutated tumors. Breast cancer was one of those, and as you can see, remarkable responses with significant duration were observed. Since then, we have a constellation of PARP inhibitors. They all inhibit PARP1 and PARP2 to a certain extent, with variable potency regarding PARP trapping to the DNA, with Palazoparib having the highest potency and Veliparib having the least potency. The pivotal trials that established PARP inhibitors as treatment of choice for patients with metastatic triple-negative mutated BRCA tumors were the Olympiad trial using Olaparib and the mBRCA trial using Palazoparib versus the treatment of choice for the physician, allowing a variety of chemotherapeutic agents, with gemcitabine being an option in the mBRCA trial, not available in the Olympiad trial. Patients that were enrolled were more or less similar, exposed to anthracyclines and taxanes. Their tumors were not platinum resistant, as defined by no progression on platinum in metastatic setting or progression after early use setting beyond 1 year. Two trials are not meant here for comparison, but just to give you an idea about the patient population enrolled in trials of PARP inhibitors. The Olympiad trial allowed up to 2 lines of chemotherapy in the metastatic setting, with the mBRCA allowing up to 3 lines, in addition to locally advanced tumors. And if patients had hormone receptor positive tumors, they allowed endocrine therapy up to 1 line, or at least 1 line in the Olympiad trial, as versus no limit in the mBRCA trial. Quite interesting to note, and we're not comparing again, is that 50% of the patient population included in both trials had hormone receptor positive tumors. So we always tend to think of BRCA mutant tumors as triple negative, but indeed they are 50-50. When it comes to the progression-free survival, as you can see, in both trials, there was a significant improvement of 3 months. Modest improvement, but still significant, with a significant improvement in response rate. So if your patient's having symptoms, there is a 60% chance of response if you're giving olaparib or talazoparib. Compare this to 20% modest response for checkpoint inhibitors in the frontline setting, not even the second or third line setting, where it goes down to only 5%. When it comes to overall survival, unfortunately, it was not improved. But notice in the elongated trials, there was no crossover because no PARP inhibitors were approved. In the talazoparib trial, you notice the tail of the curve steadying at about 20%, with 25% of the patients crossing over to talazoparib, to another PARP inhibitor in the talazoparib trial. Another interesting observation was patients who were given PARP inhibitors in the frontline setting of metastatic breast cancer had improved overall survival of 8 months. Compare this to what we have in the standard practice, up to 18 months, and now we're talking about 18 months of overall survival, median overall survival in the second line and third line setting, and even up to 22 months if given in the first line setting, about 4 months improvement if you compare to historical control. And if you compare to checkpoint inhibitors, and I'm choosing here the best subset of the keynote trial, randomizing patients with triple negative breast cancer to pembrolizumab versus chemotherapy in the second and third line setting, similar to our patients, and the best subset with a combined positive score for the PD-L1 of more than 20, you're having a median overall survival of about 15 months, and the tail of the curve is not much better than talazoparib. Let's see if we can do better combining the PARP inhibitors with chemotherapy, and Veliparib was the agent of choice, considering its least potency in terms of PARP trapping and hopefully less toxicity. It did promise in the neoadjuvant setting in the I-SPY trial when added to chemotherapy by increasing the complete pathologic response rate. That unfortunately did not pan out in the brightness preoperative trial, but still the BROCADE-2 phase 2 trial in the metastatic setting did result in non-significant improvement in progression-free survival when added to chemotherapy. So that led to the BROCADE-3 trial, enrolling patients with more or less with similar characteristics to what we talked about, exposed to anthracyclines and taxanes, not platinum resistant, to either platinum and taxane versus the combination with Veliparib, allowing for optional crossover, and then maintenance with Veliparib after chemotherapy. As you can see, nice separation of the curves in terms of progression-free survival starting at about 1 year. Quite interesting, at 2 years, you're expecting your patients on maintenance Veliparib, at least 1 in 3 will be without progression compared to 1 in 5. And at 3 years, you have 1 in 4 as compared to 1 in 10 progression-free. When it comes to overall survival, again, we do not have improved overall survival, but we do see a significant median overall survival of about 33 months. You're talking about a median overall survival for patients with metastatic triple negative breast cancer surviving beyond even 2 years, you're talking. And if you compare that to the Impassionate 130 data when atezolizumab was added to nab-paclitaxel in the same setting, and again, we're not comparing directly, but just interesting to notice, the median overall survival was on the order of 25 months as compared to what we could achieve with PARP inhibitors. Of course, no pain, no gain, but the good news is that toxicity is mainly hematological, and we as clinicians quite trained as oncologists to handle hematologic toxicity. we did learn from the trials that 1 in 4 patients to 1 in 3 patients will need dose reduction or interruption. However, only 5% needed to discontinue the treatment because of toxicity. So it's quite feasible. Compare that toxicity to the unpredictable autoimmune adverse events, sometimes irreversible. So it's a feasible option. Definitely they are active in germline BRCA mutant breast cancer. How about somatically mutated BRCA tumors? The SWOG trial did tackle that question by enrolling patients to either platinum or platinum with Veliparib and stratifying them to either those with a germline mutation versus those without a germline mutation, stratified again into BRCA-like or BRCA not or non-BRCA-like based on testing the tumor for either homologous recombination defect by Myriad test defined by a score more than 42, or somatic BRCA mutation or BRCA1 hypermethylation, in addition to germline mutation and other DNA repair machinery genes. And what did we see? In the BRCA-like group, there was a modest improvement in progression-free survival and overall survival. That was remarkable when we limit the analysis to the patients that received the treatment in the frontline setting, with improvement in overall survival of about 7.5 months, similar to what we saw in the Olympiad trial in the frontline setting. And the TBCRC trial verified the same finding when using Veliparib to treat patients with germline or somatic mutation in the homologous recombination pathway genes. And as you can see here, patients with somatic BRCA mutation were the ones to achieve the highest response rate and the most durable responses, similar to what we saw in the germline mutations. Finally, we do have proof PARP inhibitors are active in germline and somatic BRCA mutant breast cancer. Can we do better? And indeed, we do need to do better. We can combine PARP inhibitors, however, with checkpoint inhibitors because they do prepare the environment to be friendly for checkpoint inhibitors by recruiting cytotoxic T cells. And I'm sure Dr. O'Shaughnessy have talked about that. And also, triple-negative breast cancer tumors do have higher stromal tumor infiltrating lymphocytes and PD-L1 positivity, which both are characteristics of tumors that are likely to respond to checkpoint inhibitors. But my point is, I would be building on the activity of PARP inhibitors by adding those. We have the Tupasher trial and the Mediola trial combining a PARP inhibitor with a checkpoint inhibitor. However, the Tupasher trial did not select for PD-L1 status or BRCA status, and look at the response rate, 20%, more or less similar to single-agent chemotherapy in that setting. However, the Mediola trial, combining Veliparib with durvalumab, achieved a response rate of 60%, more or less 2/3, when selecting for genomic BRCA mutation, similar to what we saw with, indeed, single-agent PARP inhibitors. So, promising activity, but so far hasn't been remarkable. For the sake of time, I'm going to go back to the first slide and see. Hopefully, I have convinced you that we can slow progression really and improve survival and responses using the PARP inhibitors. Simply, it makes sense. They are targeted therapy for specific target, and they are oral therapy, attractive to the patient and feasible. They slow the progression by 40%, and it's a single agent activity, not even combined with chemo. They have promise for combination with chemotherapeutic agents, with checkpoint inhibitors. Many trials are ongoing, and particularly if used in the frontline setting. When it comes to morbidity, I believe supportive therapy and what we have learned from the pivotal trials make it quite feasible. I rest my case. I think that proves they are excellent choice, maintaining quality for the patient, quality of life for the patients, and hopefully I have convinced you. Thank you for listening. And I will be joining you live during the meeting.